Hi, so thank you for staying to the last session. So we'll try to make it fun and not too long. But the first few slides I'm going to show paint a rather grim picture of where the health system is in this country. You can see here a comparison of several developed countries, mostly Europe and Japan. The States spend far more proportion of the GDP than any of these other countries in the healthcare system. So you could say, well, we may probably have the best one, but it's not the case. Clearly, the cost of many items like surgery or some of the tests that we use is much higher than in these other countries. But what's shocking is that it's actually one of the worst systems in some of the measures, and or the worst. For example, a number of physicians per capita, or number of visits to hospitals per capita is low. The worst after hours care. Some of these you may think, well, we are healthier, but not. The actual outcomes are worse as well. The life expectancy is lower. That was shocking. I was going through these numbers. The worst infant mortality. Maternal mortality, for example, due to pregnancy complications is going down in the world, but in this country it's going up. And so on. So what's going on? There's clearly a problem. And I hope that we can see ways in which we can contribute and get it better. In particular, the use of technology seems to be a loss of opportunity. There's very little technology. There's an issue of information management and communication. This country has the highest % of errors in lab results, lab tests that are done because they are not needed or they are done twice. So there's a clear need of technology to solve some of the issues, and there's strong support of the use of technology to improve the system. The majority of the Americans support a complete rebuilding of the system. But before that happens, and maybe it will never happen, but there are lots of things that we can do using technology to improve the care. So thinking about a health suite, we are thinking about how Early Signal, my foundation, can work with CBB and CBN to establish and develop and improve a whole suite of technological tools at the service of the patients. So the platform can include the standard tests that are done in the clinic, but also, and in particular, we would like to bring apps and devices, wearable devices, and also home sensors to use in the platform, fully integrated in this platform to help the patient, the families, all the caregivers and providers and all the physicians. So how can we do this? So the tailored health suite will comprise an app. It can comprise sensors, as I say, could be wearables, or it could be in the home. And it could also help us understand what happens when people move around in their environment. So if we can take the GPS data, for example, and use it and combine with demographics and understand the context in which bad things happen. So we really have an opportunity to bring all these tools and create a much better analytical system. So surprisingly, only less than 1 in 3 of the health centers surveyed in this particular study use mobile devices, and they just use them to remind the user of a particular upcoming appointment. So there's really, I mean, everybody carries around a smartphone. So it's a huge lost opportunity not to use these smartphones to do something better than that. There are about 40,000 applications per month added to the list of apps available for the smartphone. It's a staggering number. About 20% die within 6 months of being released. And within these, the ones that are of importance for us are the ones that help with mental health. There are many apps. One of the top-rated apps is PTSD Coach, and we are going to actually have a demo here today. Apart from apps, what do we need to complement them are, as I mentioned before, the wearable sensors. We really want to fill the gap between visits to the clinic. So I go maybe once or twice in a year to see my physician, and in the meantime, things that can happen that may lead to bad outcomes that could be preventable. So can we use wearable devices to fill the gap between visits to the clinic? For that, we want to be able to capture passive and continuous data and vital signs, cognitive readouts. We want to really make full use of mobile devices, wearable devices, but also integrate data from different platforms. So how do we get to the wearable health? One of the inspirations for the Smart Cube that Magali discussed was Star Trek. I'm a Trekker. So some of you, I heard today somebody say, I never watched Star Trek. But I think most of us know what Starfleet tricorder was. It's the Starfleet tricorder was a portable diagnostic tool, and actually I have two, and they are the prize for the raffle tomorrow. Oh. So I'm going to explain how to get to those tricorders. But what's interesting is that science fiction has predicted the future many times, from Jules Verne to actually Star Trek. So nowadays there's a $10 million competition. There's an X Prize competition for the design of the real modern tricorder. So we'll see more of this. Wearables, there's an invention of wearables in 2017. About 330 million devices will be shipped worldwide. Many of these, and you can see in the graph, we have the chest band, where we have headphones, risk activity monitors, sport watches, and smart watches in that order. The smartwatches and the wristbands are the ones that have grown the most. You can see on the right panel a % increase from one year to the next. The chest bands are the ones that are probably going to die soon. They're not very friendly. In the other category, which is the light blue, we have cameras, headsets, and smart garments. These are really interesting because they are very easy to use. I'm talking about the garments, and provide some measures that could be very, very interesting for the clinic. And those are by far the ones that show the more aggressive growth. What's the problem with these devices is they are more and more, as I say, every day we hear about a new cool gadget in the, sorry, not gadget, device. I've been corrected. devices in the market. The problem is that the ones that are really affordable are not really good quality. What we want to use for these platforms are devices that provide medical grade data. The older version of these devices are really very expensive. So what we are doing is we're going through all available devices, looking for quality, but also looking for price. And not only that, looking for battery life. We want something that is not going to force a person to be charging all the time. So we're looking at devices, and in this table you can see some of these devices have only half a day of battery. That's not a good thing. And some have up to 120 days. Now, 120 days you get if you only collect 1 minute of data per day. And then you can use the device for a long time. So we need to find, what from these short list of devices that are really amenable to, good quality analytics. From the ones that are, our top list, we have partnered with IMEC or IMEC, and we are also going to have a demo. You can guess who is going to show the demo. And another thing that already exists is software for some focus analysis, and in particular, Mindstrong Health, and we're going to have a demo, looks at how people type in their smartphones and collects a lot of very interesting data. We're going to actually hear about that today. So what's the only piece missing? We have great tools, but we do want to integrate all these things. We don't want to have just one device with one type of answer and then a separate device that is not connected. So where we come in as a foundation is creation of this analytical platform that's going to integrate all these different data streams and create one signature for the individual or for a group. So, and in particular, we will focus on signatures that are specific for PTSD. So the problem we have with these type of devices and the integration of the devices is that they are very different data streams. The data is not very well behaved for many reasons. Some of the devices will send a lot of data very frequently, and some others will send data at a much slower pace. So the sampling rate of the device and the use rate of the device is going to be very different. This issue of compliance, that some of these devices may not be so comfortable, so people may leave them at home or not use them. The battery may run out. There may be other technological issues. We want to also combine these with data coming from the clinic. So for example, if there's a good omics data, we want this platform to be able to collect and integrate in the analysis any type of omics data. And that's what you can see here. So another thing we want to do, and which is implicit in what I just presented, is capture data from different domains. We don't want to focus just on one domain. If we were to analyze different domains separately, we miss the correlation between them, and we miss also a way to contextualize the data. The data from activity and the data from heart rate are a lot more meaningful when analyzed together. So we really want to create a system that integrates all these data streams. We also want to add in the contextualization using GPS. So you have, right now there are lots of maps and demographics available in the internet. For example, it's very easily you can download a crime rate map. for example, that map comes from where I live, so some areas are very green. My house is on a green area. And on the red area, it's a very high crime rate. We want to use the GPS to also understand if heart rate is going up, but the person is in a football field, then that means something very different from this person being on a bridge. So can we really be smart about collecting all this information and extracting the most important information that may be used to prevent an adverse event? So there are several types of questions. The first question, when one has an extensive baseline of data for an individual, it's using change point algorithms. One could look at changes from a trajectory and try to find predictors of that change and understand what happened, why is functioning deteriorating. Once we have data from a population, then we can look at a deviation from the norm. When did things get really, really wrong and why, as compared to a normal population. And finally, of course, we can now look at when we have a disease population, we can look at recovery from that disease baseline towards a normal baseline. So there are a number of questions that one can ask having such system. So as I say, we want to collect different domains. We want to understand which domain is more important. There are, for example, speech could be a very important domain for a particular question. If we are asking about recovery towards a normal baseline due to a treatment, maybe speech is the best measure of well-being for this particular population and treatment and question. So domain information is something that we want to be able to weigh in and out from the analysis. So the analysis that we are preparing, the analytical platform is very flexible. It can look at different domains and give different weights. We also don't want to use just one type of algorithms. It can be shown that for any particular data set, there is one algorithm that is the best, but rarely that one algorithm generalizes to other data sets. So that we don't want to corner ourselves in using one particular type of algorithms. We want to implement a system where the flexibility is there to switch from one type of algorithm to another. And finally, another of the ideas that we're using is that of an ensemble classifiers, which is a way to combine different answers from different algorithms into a more robust answer. So these are the general ideas that we have for the analytical platform. And for CBN, we have a plan. We are going to start looking at this plan in more detail. But basically, we have a phase 1 development. We are going to have pilot data collected with Dr. Marmar and Dr. Akin. We are going to use that data to improve on the devices and the algorithms. Eventually, in phase 2, we want to deploy in the network. And eventually, on phase 3, to extend and optimize and close the loop. And what I mean by closing the loop is that tomorrow we can implement something where there is a smartphone, there is an app, and that gives immediate feedback to the user. And on the other hand, you have the physicians and care providers. We want to close the loop in the sense that we can go all the way from the person through the devices back to the person, to the clinic, and back to the patients. And so this is the stage 3. This is where we're going in the next few months and years, hopefully months. And so right now, I think this is the end of my talk. What I would like to remind you is there was a survey that at registration. There's still copies there, so if you haven't seen yours, please fill up this survey so we have some feedback on how you interact with apps. And tomorrow, during the first break at 10, we are going to have the speakers available for more demos and discussions. And I ask you that you bring the survey filled in. We are going to have 2 winners, and there are 2 tricorders ready for these 2 winners. So thank you, and Paul, you're first.
Thank you. Done. Just set this up. Looking for the HDMI. Well, I'll get started with the presentation, and then we'll set that up here. All right, thank you, Dani. Thank you, Dali. So let me get back here one. So we live in an era where big data and AI is transforming the world. I'm reminded of that every day. I live in Silicon Valley. And I drive around, I see the Google cars, the autonomous vehicles driving around my neighborhood. So it's a very interesting area. Another, of course, another big opportunity with data and AI and the transformation it's making is in healthcare, and biosensors is a big part of it. What I'm going to talk to you today, and hopefully we'll get to the demo here very quickly, very soon, is how we're planning to really reshape and transform the way we, a 70-year-old practice of neuropsychological assessments. So we'll start with how it's been done for the past 70 years. Psychological assessments, as neuropsychological assessments, I'm sure I don't need to get into the details, but they're all suffer from a certain set of limitations. They're pencil and paper. Some of them have been put on laptops and tablet computers, but at the end of the day, these assessments are obtrusive. They require hours of psychometric testing. 3 hours is a pretty average test run. They're not ecological, so that they're not testing the individual in their environment at home. So someone can come in to see a psychometrician, be tested. They're going to usually do really well in the test environment, and not so well at home, right? And so you know, clinicians suffer with the disparity of the results between what the patient reports and what the psychometrician reports as the test results. They're episodic. Typically, you'll do one maybe once a year. They're hard to repeat. The tests are standardized, so the patients will start to learn the questions and learn the answers to the questions. So normally, it shouldn't be repeated more than once a year. So you're really getting very infrequent snapshots of that patient's cognitive and psychological assessment. And they're poorly scalable, because when we look at a world where we're trying to scale and use and leverage technology to scale healthcare and healthcare reach, and we're thinking of population health, bringing someone in for 3 hours of testing is a challenge. So our challenge was how do we develop an unobtrusive way of measuring neuropsychiatric health continuously in an ecological environment. So we embarked on a long project, a multi-year R&D project. We ran 2 clinical studies, 140 patients in 2 clinical groups. There was a group that was 50 and over, and then there was a group 18 to 35 with depression or anxiety. It was a multi-year study. Each participant would come in, underwent a full battery of neuropsychiatric testing, 3 hours by a psychometrician. We installed an app on their phone, and I'm going to demo the app here in a minute. And the insight was that the way we use technology and the way we use the smartphone, those swipes, those patterns, those searching for that phone number, the typing, the backspacing, the latencies, those small latencies and delays were repeated psychometric experiments. And if you've ever looked at some of the psychometric tests that are used today, the pencil and paper, you can see how they start to translate into that repetitive activity that we do on a phone, on a smartphone. And it's not really specific to the smartphone, but the smartphone is ubiquitous. It really translates to the way we use technology in general. For us, the advantage of the smartphone was, of course, its ubiquity, and when we're looking at something that would be passive in the background and ecological and continuous, it was a very good solution. So at the conclusion of the two studies, at the end of the study, the participants were tested again. This was a year later, basically, from when they started. We collected data for the entire year. Here's one set of validation results from the 18 to 35 cohort. What you're looking at here is the various cognitive metrics, so the psychometric assessments that the psychometrician ran. These are the tests at the second testing, which was a year out. And what you see here, the last column, the R predicted, was the predictions of our analysis based on the data from the first month when they came in, based on the data we acquired from the passive phone usage. So we were now predicting based on the data acquired. So the algorithms were trained on the first test, and then these are essentially holdout predictions a year later. And you see really quite good correlations, comparable with a lot of the test-retest correlations that you get with these psychometric assessments. We also ran some construct validity on this, where we looked at the covariance matrix and the factor analysis of the various tests, and naturally they all loaded on similar factors, so we were very happy with the results. So now to make it a little fun, because it is the end of the day, and just to show, and really just to sort of pique your curiosity of what are the things that you can do when you start to really collect psychometric data on somebody essentially continuously every day. So these were just some random questions. As I should mention that as part of the study, we equipped the participants with jawbone up bands, so they could we tracked their sleep, and we tracked their steps. So here's a couple of questions. Does being more active during the day improve memory performance? And does getting more sleep improve your executive function? Right. So in the interest of time, these are the two questions. Here, these are unique to each. So we're looking at precision data here, precision neuropsychometric assessments. So each one of these is one participant. On the left, what you see is one of our features for memory. Or one participant on the y-axis is the feature measuring memory. And on the x-axis, what you see is the number of steps. And you see that when they're more active, they actually are doing better. The actual raw features that we're extracting that correlate with memory are actually improving. And then just quickly here, so we can get to the demo in a few minutes, in a few seconds. Does sleep improve executive function? Executive function here is task switching, sort of your ability to plan out things. And again, what you see here on the y-axis is one of the features that correlate highly with executive function. And what you see on the x-axis is hours of sleep. And you see that, yes, it does. And these are actually, again, each one of them is unique to one individual. So it's data from a single individual. And I think that's important, because I think the amount of how sleep affects any or lack of sleep affects any one of us is truly an individual thing. So let me let's switch. Great. Okay. All right, we can switch, please. Sit up. can we switch to the HDMI input? Or actually, I think it's the, here, let me. All right, that should do it. There we go. Okay. No.
Oh, you had it.
Yeah, very briefly.
What happened?
If someone could just switch to the HDMI. Okay, thanks. Any questions while we wait? All right, beautiful. Thank you. So what you see here is, this is the phone I have, right? So you'll see, I should see, yeah, there we go. And what you see on the top are the raw features. These are extracted directly from the phone. They're going via 4G to AWS, Amazon Cloud Servers, and that's a shell opened up on those cloud servers. And on the bottom are the process features that are being extracted as part of the processing pipeline. So what you're going to see is, here's my phone. Let me just go back here. Let me open up this. So you see each action, each swipe, each tap generates something on the top. And then eventually you'll start to see features being extracted when it sees enough data, enough repetitive data. So I'm opening up. Let me start to just type some stuff, and you see some of the features being extracted, and the process features being extracted in the bottom. You sort of start type some random symbols here, and I'm going to just backspace all through that. Let me go here. Let me go to settings. Let's say I'm just scrolling here. You should start to see some activity. You should see some activity. There we go. So let me go over here. Let me, let's see, look at Facebook. So one of the things that we, of course, did because of all the privacy issues, I mean, if I type in here, you see some more features being extracted. If I go to the password, nothing gets pulled out, right? So we detect the password, the app detects any password field and obviously just blocks that out. Because we don't want to be extracting anything that we don't need to know. So that's it. I mean, if I go to my email, again, you start to see, scrolling here. There's not much to scroll in this test email box. But that's basically the concept. So anything I do on my phone is going to, the features are going to be extracted in real time, sent to the cloud servers, processing pipelines pulling when it sees enough repetitive data of a certain type, starts to pull out various signal extractions from that. Those features in the bottom one, the features that are being extracted, are the ones that you saw here in the presentation just a minute ago in the slides. There's close to 700 distinct features that we can extract. Consistently, out of the 140 participants, there was roughly 280 plus features that were consistent across both groups of participants. So that's what we've been using. That included participants well in their 70s. So it's a pretty consistent and stable set. That's it. Thank you.
Thank you. Thank you.
All right. Good afternoon, everybody. Thank you, Magali, for the invitation. Thanks, Danny. I'm going to talk today about some of the wearable devices that we've been working on at IMEC. For those of you who don't know IMEC, we are a research organization headquartered in Belgium, where we do a lot of semiconductor and electronics research. So technology scaling, making transistors smaller and smaller. And in our free time, we also develop wearable devices and also life science technologies, including neuroprobes that I think some of you know. But today I'm not going to talk about that. I'm going to guide you through a brief journey through some of the work we do in wearables. So what do we want to achieve in our wearables activity? It's all about bridging the gap, as Danny was saying. So we built prototypes that we take through research to clinical trials and ultimately to products and into real people. Today I'm wearing 3 devices actually. One of them was more obvious to you guys. It's a headset. I'm not thinking every veteran has to wear one of these, don't worry, not for too long at least. I'm wearing also a patch that you can't see, but it's here, right here, and a smart band. It's not a watch, doesn't tell the time. And I'm going to show you real time what those devices look like, what those signals look like. Very important is that they are not gadgets. They are medical quality data devices. So that's really important for trials. We need to make sure they are safe. That's also important for the FDA guys. We need to make sure the quality is the right quality, but also they need to be comfortable. They need to have very low power. So it's a whole lot of things that we need to do to make them mature enough. So it's not a research, let's say, desktop university device. It's not a product, but it's getting there. All right, so I'm going to jump to the first device. So basically, I'm going to stream some video data over that screen in a non-flashing mode. Right, start there. So what you can see here is I'm streaming right now real live data from my brain. And to some of you, well, this is a little, kind of freaky to some of you guys. To other guys in the audience, probably you can even read EEGs, so you probably know everything about me right now. For people like me, we need to do some post-processing, or a lot of post-processing, like people like Danny. So what can you see here? Maybe a little test is I'm going to clench my teeth so that you see, oh, sorry, what's that? Windows. Yeah, so that I'm going to clench my teeth so you see real life data. So right, something's happening here. Another little test, I'm not sure if you're going to see it with this screen resolution. I'm going to close my eyes, and then you typically see some alpha waves around 10 hertz. It's maybe not so easy, but you should see a little ripple on some of those waves. Well, that's pretty much it. So it's 8 channels of EEG in this particular device. I'm going to take it off. I'm going to tell you a little bit more about it. So what's so special about this device? Well, first of all, as you can see, I can put it on, I can take it off, and immediately you get data streams coming out. That's quite a game changer. Well, it means that you don't need to be really skilled. Well, I should choose my words very carefully now, but you don't need to have a PhD or be an MD to be able to put it on someone's head. So you can imagine working with this in the field for concussions or a lot of different applications, bring it closer to point of care. We've been validating this a lot against medical grade. The second aspect I would like to highlight, you see a lot of rubbish right now, of course, because I'm not connected, is that this is totally a dry system. So we don't need any gel electrodes. That typically will take a skilled nurse maybe 10 to 20 minutes. Is fully based on dry electrodes. So in fact, we took it one step further. We designed the entire system based on that concept. So we redesigned the complete electronics. Even the chips in here, which is what we love because what we do best is electronics, the chips that go in here that do the first, the chips that go into behind each of these electrodes do the first pre-processing have been optimized for EEG. The electrodes themselves are rubber-based electrodes. Yes, they are not metallic-based electrodes. So we've developed these ones with one of our partners, looking for the right compounds, polymer-based, good performance versus good comfort. And we got to a pretty good stage. So as you can imagine, there are a lot of applications, TBI, but also neurofeedback-based applications, stroke rehabilitation, and so on that we could do with this device. All right, in view of time, I'm going to switch to the next device. All right, a much more recognizable signal for many of us. So I'm streaming right here, ECG real time, so that's full waveform, as well as accelerometer data, and that's what's down here. So it's XYZ. So what can we, now why is that useful? Well, we can see what people are doing. We can get some additional information. Is the person lying down? What's the heart rate? Is performing an activity? What activity that is? We can detect all of that. So that's medical grade ECG that we have developed here. So I'm not going to show you the one I'm wearing on my chest because I'm told this is being streamed and maybe children watching at home. So instead, I brought another one with me. I have to admit it's not exactly the same one, but it's actually a newer version of it. So this is a single lead ECG system, and the complete electronics looks just as small as this. And this is a complete system right here. Processor, Bluetooth low energy, 3-channel ECG, even a bioimpedance circuit that we developed ourselves as well. So what can we do with this? In fact, the chip itself can do up to 3-channel ECG. So we are able to get accurate respiration monitoring together with 3-channel ECG. So you can imagine we are looking at a lot of cardiorespiratory different type of applications, even body water disorders based on this type of technology. All right, next. So I'm switching again. So maybe you don't see it. There's a little something here. It says GSR. All right. So this is live information coming from this one right here. As I mentioned, it's a band. If it told the time, it would be a watch. It does look like a watch. And in fact, in the next version, which is coming out in October, it's coming out with a display and some more stuff in it. So what can we see? We see the GSR. You see the signals here with 2 different scales. Well, short term doesn't tell you too much, but well, if you look at my data 2 hours ago and now, you can probably see a bit of a change. But we are interested into long-term monitoring of those signals. So today we monitor skin temperature. So it tells us something, how the physiology changes typically in the limbs when faced with stressors. Also GSR, as I mentioned, the skin conductance, and again, accelerometer data to tell us something about the contextual information. In fact, all of these signals that I was talking about just now, we can synchronize all of these. So that's very powerful for trials. In trials, we typically do an overkill, so we monitor more signals than we need. But we need that to better understand disease, disorders, and how to come up with therapies, how to come up with better diagnostics. All right, so that ends the kind of demo part, and I go back to slides. Oh, sorry. Back. Okay. So what I'm going to give you a couple of examples to show you that this stuff actually ends up into products. We want to make sure that this stuff ends up into products. So we need to develop all in parallel. We do devices with trials and algorithm development in parallel to, okay, how do we get this through FDA? How do we get it to actual products, actual applications? So 2 examples. I'm very happy to say that in partnership with biotelemetry, we have taken through FDA, or they have taken through FDA, an MCOT device, a mobile cardiac outpatient telemetry device. This was announced back in July by biotelemetry. There's very little I can tell you about this device because this is what our partner made public. But I can say it's an amazing device, so stay tuned for more news on that one. Biotelemetry is a market leader for arrhythmia monitoring remotely, so you can imagine in what direction this goes. Another example also released in July. This one I'm very happy that I can show the picture to you guys. It's a wireless EEG portable device. It's the first of its kind. It has been released by Nihon Cohen. We've developed this with them in partnership. It's a device that goes into intensive care units. It goes into ER, emergency rooms. And it's already there, has been released already as a product, approved according to the Japanese medical standards, which I guess is not a piece of cake either. It's not FDA, but also quite an achievement. Ultimately, it's about the applications that we can enable, and we've been talking about stress a lot today. PTSD, for us, that's a very important area. It's a very big challenge. It's a multidisciplinary challenge. We know it's really hard, so we need to definitely join forces with a lot of different institutions, with Cohen in this case. Today at IMEC, we've been working on stress monitoring and management. Our focus so far has been pretty much on prevention, in fact, on stress at work. So looking more at healthy populations, how do we make sure that people don't reach burnout, that through habit and behavior changes, that stress can be managed. We are doing this together with a mental health institution, a mental health unit in a hospital in Leuven in Belgium. In fact, we are running a large-scale trial, or at least that's how I called it until today, after all these very impressive talks. We are running a study with about 1,000 participants, and those are wearing 2 devices, a patch, the one I'm wearing right now, in fact, and a stress band, chill band, for 5 days continuously. Hence why low power is so important indeed. Also with a smartphone app, so that there is additional contextual information. And we are coming up with new, advanced, personalized algorithms to estimate the amount of stress that these people undergo. So that's part very much of the research. Next, of course, we are really interested into therapy follow-up, PTSD, depression, burnout, as it has been mentioned today. And again, ultimately, it's about bridging that gap, bringing research to products, bringing it to real application, and we want to be very much a part of it, together with Cohen, I'm sure, and with all of you guys, that we can achieve this. Thank you.
Big one. Yeah.
Hello, everybody. Can you hear me okay? Great. So I'm going to tell you a little bit about the other end of using these technologies. We've been focusing a lot on diagnosis and assessment. At the National Center for PTSD in the VA, we've been thinking a lot about how to harness these mobile apps to improve treatment delivery and improve treatment effectiveness. And as I survey the field of PTSD treatment and mental health treatment generally, I see a number of major obstacles delivering effective care that are quite thorny challenges. They're sort of wicked problems. And I think that mobile technologies are extremely important because they hold potential for simultaneously addressing a number of these challenges that we face. The first, of course, is in delivering effective care. We know that much of the care that's out there in mental health is not evidence-based. There's this large gap between research, what the evidence shows, and what practitioners are delivering. Difficult to know how to do anything about that, but apps, I think, can arguably do it in a number of ways. One way is relatively straightforward, and that is we can build apps that will support the delivery of evidence-based treatments. I'm going to describe a couple of those to you. So that's, at some level, they can just make it easier to deliver the face-to-face interventions that we know are efficacious. I also think, and it has to be tested, that apps themselves have a number of delivery features that should enable us to just be more effective in general. If you look at cognitive behavioral therapies, how do they work? Well, there probably are cross-cutting elements, procedural elements, which underlie the effectiveness of psychosocial interventions. They're pretty often fairly mundane things. One is very concrete goal setting and regularly testing yourself against those goals. Another one is self-monitoring. There are other skill sets like teaching people self-management tools for managing states of distress. And I'll put it to you that these technologies are uniquely well suited to magnify our ability to implement these things. So right now, if we do our traditional evidence-based cognitive behavioral therapies and want to have somebody self-monitor their behavior, we sit in an office with them, we ask them to do this, and we give them a piece of paper that they have to fill out. Whereas if we can give them an app, that app's going to show them instantaneously how they're performing on things. It can remind them to complete their self-monitoring. It can store that self-monitoring data, probably improve its fidelity in many ways. So first, it can improve the effectiveness of our treatments. Probably the greatest weakness of mental health care delivery across all systems of care is the fact that we don't, right now, have measurement-based care. That is, very few treatment systems, very few practitioners actually monitor the outcomes of their treatment, which means that all treatment decision-making is not informed by arguably the most important thing, whether people are getting better or not. Right? So as soon as we start to harness these technologies, though, it's going to be relatively straightforward to ask them to complete whatever outcomes measures we want in ways that are easy, convenient. They don't have to come in for a special session, and they can be reminded to do these things. So it sets the scene for us to begin to develop and implement measurement-based care, which I think is the game changer for mental health care. Now, we also have a problem with not really having enough mental health providers to do all the things that we need to do. Even in well-resourced systems, I would argue that we don't have the right patient-to-staff ratio. And if you look around healthcare systems, you see us sort of cutting corners and seeing people for very few visits. It's difficult to do that. To meet with people with the degree of time intensity and regularity that we need to help them. So we need to find ways to improve the impact of a therapist while holding constant or actually reducing the face time that they need to work with the patient. We also have a very big problem in training. One of my fields, I'm the director of Dissemination and Training Division of the National Center for PTSD. So I've been doing randomized controlled trials of training. Well, I think it's a dirty little secret that it's extremely difficult to train practitioners, to develop their skills, and to move the needle on what they do in routine care. It can be done if enormous resources come into it. I was privileged to be one of the leaders of the rollout of prolonged exposure in the VA. We had world-class training, very intensive 4-day workshops, followed by a minimum of 2 cases under weekly telephone supervision with an expert. That kind of training works. People learn skills, they come away being strong advocates for the treatment. But how scalable is that? That's not scalable for the array of things we need to train people in. So I would put it to us that if we can outsource many elements of treatment into these technologies, certainly the didactic components, but probably many of the other elements as well, then we may be able to reduce the training burden on practitioners, and that should help us get around that. We also have a big problem, don't we, in the stigma associated with mental health care for our veterans and active duty service personnel, also the logistical barriers which are often associated with dropout from treatment. As soon as we begin to put these things on technology, we can have individuals working in a very powerful way with their clinicians from the privacy of their home. So we reduce the logistical barriers, we reduce some of the discomfort associated with face-to-face visits in many ways. And then I also think that I'm an advocate for kind of treating the whole person. So it's all great to be focusing on PTSD interventions and working on PTSD symptoms using PE or cognitive processing therapy, but that person probably has a number of other problems. Very difficult to devote the therapist's time to help them with a whole array of difficulties. But as we're working with them on PTSD symptoms, it's possible we can ask them to work through modules 1 and 2 of smoking cessation or to download the Parenting to Go parenting skills app, and we can begin to help a person with a larger array of the challenges they're facing. So because of these arguments, at the National Center for PTSD, we've started a program of attempting to develop these apps and to begin to explore them in a variety of ways, which I'm going to describe to you. I just want to acknowledge that we have a talented team of people. Julia Hoffman has been very important in spearheading the development of many of these things. She was the head for mobile health for mental health services in VA. Eric Kuhn has emerged as a leading researcher in this, along with Jason O, and we have a talented team of developers that are behind the things we've been doing today. At our division of the National Center, we have about 10 other investigators that are adding this research domain to their portfolio. So we are trying to do several things. We're trying to begin to develop apps and conceptualize how to build them. Some for self-management, that is, helping people manage their own symptoms or engage their own skills to change their own behavior or deal with their own emotional challenges. Some to support the delivery of face-to-face delivered evidence-based protocols. And then one or two for prevention. We have an app that's shortly to be released that's designed to prevent the development of PTSD and is based on some cognitive behavioral interventions we developed for face-to-face delivery. We're studying the efficacy and the effectiveness of apps and also beginning to study the implementation of these things. We're measuring the attitudes of mental health providers especially, and we want to expand that to the clients that we see to find out already at this early stage what's it going to take to increase uptake. What do they like about it? What are the perceptions of the end users of these things? And then we're also launching some initiatives to bring them into care. So here's what we have done thus far. I hope you can see this. The granddaddy of all our apps is PTSD Coach. We developed it about 6 years ago. It was kind of a bootleg project, a skunkworks project. Got a lot of attention and has become something that's being used a great deal. For me, it's a kind of a proof of concept. I regard all of our apps as versions 1.0. They are not what apps of the future and mobile interventions are going to look like. What they are early initiatives to begin to build this out and enable us to develop them further, conceptualize them, and evolve them over time. But PTSD Coach itself, which I'm going to describe in a minute, has now been downloaded over 240,000 times in 96 countries. Now that's without any kind of orchestrated marketing campaign. And in fact, the rate of downloading the app has remained stable, about 50,000 per year, with no real budget or no real effort going into marketing it. So for me, that's very interesting. Now, it's also true that some of the other apps that we've developed, we have an app called CBTI Coach, Cognitive Behavioral Therapy for Insomnia. It's an evidence-based, face-to-face delivered insomnia intervention. We developed an app which we give to patients and enables them to collaborate with a therapist and follow through with the intervention itself. You will see that that's been downloaded over 80,000 times. Some of the apps, Mindfulness Coach is an entirely self-administered mindfulness training tool. It's kind of going viral. Lots and lots of people are interested in mindfulness. We're not really doing anything thus far to really train and support the delivery of these things, and yet they're taking off. And you can see that there's a whole host of these apps that have been developed. There's an app for evidence-based smoking cessation, Stay Quit Coach. There's Concussion Coach. There is an app called Moving Forward, which is problem solving for depression. We have an app for parenting skills training because we know that parenting concerns are big amongst our veterans. And we have a suite of apps like CBTI Coach, Prolonged Exposure Coach, Cognitive Processing Therapy Coach, ACT Coach, and so on that support the delivery of evidence-based face-to-face protocols. And they're all getting much used. It's interesting. We've trained about 2,500 plus VA mental health providers in prolonged exposure therapy. And our surveys have indicated that to date, around 50% of those trained in prolonged exposure have incorporated the PE Coach Act into their care, which is an enormous rate, and that number is going up consistently. And it is true that the provider attitudes towards these technologies is actually very supportive. Years ago, I was interested in developing web interventions, and I think the attitudinal obstacles of getting people to incorporate web interventions into care was going to be a formidable thing, except that the apps were then developed and apps became part of all our lives, and that has significantly reduced the kind of obstacles to using these in care that we might have anticipated. So just for a moment, take a look at the screens on these. You can see these treatment companion apps which support the delivery of the face-to-face care. And in principle, they're really tremendous things. PE Coach has a number of core features. Barbara Rothbaum, I know, is in the audience. She's one of the developers of this. These apps have largely been collaborative enterprises. We worked a lot with the National Center for Telehealth and Technology, T2, in the Department of Defense, and a lot of other collaborators. I'm going to show you an app that Terry Keene's group developed, a web intervention called Vet Change, to reduce alcohol consumption in veterans with comorbid PTSD and alcohol problems. And we have collaborated with his team to develop an app which will essentially deliver that intervention. And PE Coach enables the veteran to follow along. It has all the psychoeducational content associated with each session. It has the ability for the person to keep records about their in vivo assignments, to score their subjective units of distress as they're tackling situations. Most importantly, they can tell their trauma narrative into the app and listen to it. So it makes it much easier for patients. Now, one of the reasons why I'm very excited to be talking with Magali Haas and Cohen Veterans Bioscience is that inside the VA, all the apps that I'm describing to you have sort of been neutered in the sense that they don't have data gathering capabilities, right? So that's where the special power of these things is going to emerge. Right now, these are essentially psychoeducational tools with some oomph because they often include some very powerful skills training elements. But imagine a prolonged exposure coach or any of these other apps which now present on a dashboard to clinician and patient and enable them to mutually review the progress in assignments, the symptom changes, all the kinds of things you'd want to know in terms of your client's progress with the treatment. That is, I think, going to emerge as a game changer. And I hope that we're able to do this outside of the VA and then show that back to the VA and help them see the directions in which we all need to move. So PTSD Coach is sort of the granddaddy, and again, it's here as a proof of concept more than anything else, and is being used a very great deal. Here are the sort of key features, and this is interesting because these 4 elements that went into PTSD Coach, I think, are the hubs of the things that we need to build out and explore with more power. When we first started to build a phone app for veterans, we went to veterans. We met with about 80 of them over time and said, hey, we're going to build a phone app. What do you think you want on this thing? And what they told us is what they really wanted was help with managing immediate distress. And so we conceptualized PTSD Coach as a tool, especially a just-in-time tool. That's one of the things I love about apps. They're sort of 24/7. You can pull it down when you need it. If you have a problem, if you have an alcohol urge, or if you're experiencing physical pain. In this case, veterans with PTSD want to manage acute distress. So that's what this was about. And it has 4 kinds of elements that I think we've incorporated here and we can get better at over time. One, of course, is psychoeducation. Psychoeducation is a core component of all psychosocial interventions. And on this app, we have a lot of information that's bite-sized that we give to people. They can read it or they can listen to it. We also have a self-recording function, a self-monitoring function. Veterans can take the PTSD checklist. It will give them individualized feedback on their scores, but it will also then invite them to fill it out on a pre-arranged schedule, weekly, every 2 weeks, every month, and it will cumulatively display and record for them their changes in symptomatology over time. And we think that that's something that in itself can be a reactive intervention, but also then can be something that can be helped to discuss with the client to help mobilize him or her to seek treatment. We believe that in primary care, for example, when someone screens positive for PTSD in the VA, but they're reluctant to go to specialized mental health care, if we can give them this app and begin to help them monitor their symptoms over time, it enables a lot of helping discussions that when the veteran is perhaps more receptive, we can get he or she to go to specialized mental health care if they benefit from it. Then there is a coping skills component. On this app, we broke down common complaints into sort of 8 domains you can see up here. But what you can't see is that there are some really pretty powerful interventions. For example, the veteran can go through progressive muscular relaxation training on this thing. It has visuals, it walks them through it. Or they can engage in imagery-based rehearsal exercises for relaxation with waves lapping on a beautiful shore. And there's also diaphragmatic breathing training, slow breathing training, which helps person pace their breathing and has really great video graphics to enable person. So the sky's the limit on what can be put on apps that support the kinds of active coping training initiatives that really underlie most efficacious psychotherapies. And then finally, we have a support function. Social support is one of the important things for helping people not only recover from PTSD, but also improving their quality of life. So we've designed it so it makes it easier for people to reach. We've had anecdotal reports on a number of occasions from the Veteran Crisis Hotline, crisis counseling line, the suicide prevention line, where an active duty person has called them up and they've said, well, you know, how'd you call me up? Well, my phone told me to call you. So if a person is using some of the skills and their SUDS levels or the stress levels are very, very high at 9 or 10, it will recommend to them that they might want to consider calling the hotline for support. So it makes it easier to mobilize support. And this is sort of the original model of something we've done. Now, apps are like everything else. We're going to have to develop systems to ensure that a person will stick with these things in order to get a therapeutic dose. We know from research on web interventions for mental health problems that you can't fling a web intervention at someone because people drop out of it at very, very high rates. But what we do know is guided self-help can be very powerful. And there are many different ways of guidance. Some can be automated, but others can be done by brief follow-up telephone calls from peer coaches, all the way to embedding it in full-bore psychotherapy sessions. We need to study the parameters. I think it is highly likely that we will need to supplement apps with this kind of other support services to make sure that they use the app to get the therapeutic dose they need. But what is encouraging, and first, so the bad news is that about 40% of people who download PTSD Coach don't open it up again. So there is a lot of dropout from using it. But also I found this quite hopeful. If you look down at the lower bullets here, more than a quarter of people were continuing to use the app more than 3 months after the download. And so you can see that smaller percentages of people really engage with these things and use it for a long period of time. And what that says to me is, boy, these things can have therapeutic muscle. There's no reason to believe that it can't have a significant impact on a person. And this is just a public health intervention, right? We throw it out. If we can get 100,000 people or 240,000 or 2 million people to download this, and if 5% of people or 8% of people are using on a regular basis and experiencing benefits, that is an enormous public health boon that far outstrips what we could do with intensive face-to-face psychotherapy. And that's without any support services to increase the rates of utilization. So as I said, the app was designed to increase self-efficacy. We measured self-efficacy in a couple of studies, and you can see here that people assigned to get PTSD Coach experience improvements in their perceived self-efficacy, and the waitlist control group doesn't show those changes, but when we give them the app, if they want it, what was interesting, by the way, is people whose symptoms continue to be problematic are much more likely then to download the app at that stage, but then we see a similar improvement in their self-efficacy. Now, this app was not designed to treat PTSD, but we have seen some significant fall in PTSD symptoms for many people that are using the app. And I will say that, again, we can beef this kind of an app up tremendously with a lot more therapeutic muscle. But you can see here, we took a look at the percentages of people using the app and in the waitlist control that showed what we thought was this DSM-4 criteria for PTSD symptom reduction of a change of 10 or more points on the PTSD checklist. And we found greater rates of clinically significant PTSD symptom reduction in people that were using the app compared to individuals in the waitlist condition. So we have some reason to believe that this already is helpful. Eric Kuhn's doing a large randomized controlled trial now that will test this in more detail. But again, for me, this is more of a proof of concept. We're learning how to make these apps. The app that I just showed you is our first stab. But now we're learning how to give them more functionality, and we're exploring for a range of apps many different kinds of functional tools within them. Behavioral activation, for example, positive activity scheduling, mindfulness skills. We now have, you can see the alcohol reduction app here, Vet Change. We've just released PTSD Family Coach. Now, I think PTSD Family Coach will be much bigger than PTSD Coach because families are hungry for things. So this app not only helps families understand PTSD, talks to them about how to motivate their loved one to get care, but it also helps them manage their own stress because it's very stressful being in a family with someone with PTSD. So it's designed to assist them.
1 minute.
Okay. So here's some other products that you can see. I want to highlight the one on the right is our prevention app. And we have an app for emotion regulation. And we have an insomnia coach coming off, which will be entirely self-administered. So it will help people with sleep difficulties and do it themselves. Our current app supplements face-to-face delivery. So we're very pleased to be talking to our partners, Cohen, Veteran Bioscience, about building out a version 3.0 of the app that will have more intervention muscle, will begin to use the kind of remote sensor monitoring that we've been hearing about today in the physiological monitors. Also incorporate, I hope, some ecological momentary assessments so we can study the processes. So I think we can give a lot more power. We can use it not only to intervene more effectively, but to get more data on how we're affecting individuals. Future model of care will I hope, I think that these technologies will entirely disrupt mental health care, and that we'll be able to get public health messages out, enable a lot of people to down-use it, and then we'll be able to explore triaging people to levels of care. Self-management first, but if they have difficulties with that, then we'll step up the level of support that they need. And this will, I think, be a key way in which we can move towards measurement-based care and enable decision-making by both patient and therapist based on their outcomes and whether they're benefiting or not. Thank you.
Okay, thank you.
Excuse me.
So I think we ran out of time for questions.
Yes, we did, but I think, of course, we're going to have tomorrow, the team will be over at the networking break, and you'll have the opportunity to speak with them about these different platforms and probably even play with some of the toys as well. So, not toys, devices.
Right.
Thank you very much.
Thank you.